Hi everyone, today we're going to be learning about hemodynamics in the context of dialysis and patient transport. To begin with, we're going to go through a little bit of the key concepts of renal circulation, such as the kidney's function in managing blood pressure through neural and hormonal mechanisms. The hormonal mechanisms specifically are through the RAS axis, in which renin increases vascular tone through the afferent signals that arrive at the juxtaglomerular apparatus. The kidney is a very densely innervated organ, and therefore, due to its input of receiving around 20% of the blood circulating from the heart, it's going to have a very good gauge of what a patient's blood volume status is. The kidney's function is to remove toxic waste such as ammonia, urea, as well as other electrolyte imbalances. And in the case of chronic kidney disease or other conditions such as acute kidney disease in the context of poisoning, there may be a need for patients to undergo dialysis. And over here in the slide, we can see some of the most common prescriptions for dialysis, which are gathered within the Kidney Disease Outcome Quality Initiative guidelines. And they usually include either symptomatic manifestations such as of high uremia, such as pericarditis, encephalopathy, hyperkalemia, and fluid overload. However, they can also be gauged with the measurement of GFR, which is a glomerular filtration rate. Any rate that is less than 10 milliliters per minute are gonna suggest that patients should receive dialysis to be able to cleanse the blood appropriately. In the context of acute kidney injury, we can see patients suffering from acidosis, electrolyte imbalances, in the context of, like I mentioned before, some sort of poisoning. The importance of electrocardiometry should be underscored because it can aid in the diagnosis of a sort of impairment when dialysis is occurring in the moment of dialysis. It can allow us to follow up in treatment. It can allow us to further titre different pharmacological agents that patient may be consuming. And it's going to give us a very close approach into how a patient's flow, volume status, and cardiac function is doing without having the need for invasive parameters. We can use electrocardiometry to, in summary, gain a complete hemodynamic picture of a patient's status. It's important to understand that blood pressure, which is the standard parameter that we would normally use, is going to be normal, while we could be detecting changes within hemodynamic parameters in around 15 to 20 minutes prior to any change in blood pressure. This is because we measure intravascular volume as well as cardiac contractility through electrocardiometry, and essentially traditional blood pressure measurements are not going to give us this type of quick and continuous insight that is operator independent. So what are the applications of electrocardiometry within the context of hemodialysis? As you can see over here, this is one of the techniques that we can rely on in hemodialysis, and there's also an alternative peritoneal dialysis, which not all patients are candidates for because it requires a certain level of dexterity to apply the treatment to yourself. Within hemodialysis, as we can see, this patient needs to go to the dialysis unit around 3 to 4 times a week, and it does take a very long time because the plasma filtration is going to be very slowly removed in order to assure that a patient's hemodynamic status is adequately maintained. Here are all the components which are beyond the scope of this class of a hemodialysis unit, and there are certain complications that we need to be aware of when providing a patient with hemodialysis. It's obviously going to depend on the type of hemodialysis a patient is undergoing. However, we can have vascular access complications, cardiovascular complications. One of the most dangerous and common complications of hemodialysis is intradialytic hypotension. This is why electrocardiometry is very valuable, as we can measure and in a continuous way a patient's hemodynamic profile before they decompensate, before there is an onset of hypotension, and be able to understand what the rate that would be most favorable for them what the most favorable rate for them would be, and therefore tighter not only pharmacologically but also probably the plasma filtration rate undergoing in the hemodialysis. As I was mentioning, intradialytic hypotension occurs in around 10 to 15% of patients, and it needs to be defined as a blood pressure that falls below 90/60. It's dangerous because it does cause ischemic stress, and it also is associated to increased mortality. It's recommended that a patient will have stable weight between dialysis sessions, and sodium consumption is associated to a worse prognosis. This is why it's very important in the transcourse of hemodialysis to measure urinary volume and potentially evaluate if a patient would benefit from treatment with diuretics. The temperature of the dialysate is also extremely important because any shift in temperature is going to cause for vasodilation, as heat is going to facilitate the onset of vasodilation, and this can cause for a patient to be destabilized. It's also important to consider that patients shouldn't eat while receiving dialysis because this causes for the blood to be sequestered within the splanchnic circulation, and it can also lead to hypotension. Essentially, when patients also are suffering from diastolic heart failure or have any sort of condition in which there is ischemic stress on their heart, this is also going to release hormonal signals such as adenosine, and there's going to be a blocking of noradrenaline, which can further worsen hypotension. It's important to know that patients with systolic dysfunction can be treated with verapamil, and it can be avoided, this intradialytic hypotension, through use of nasal oxygen as well as a blood transfusion in very severe cases. So as we can see over here, we have a diagram of what the standard monitoring techniques are in the common practice, which would be heart rate and blood pressure, and the insight that we can receive through using more advanced non-invasive monitoring. We can get input into a patient's preload status, essentially how much volume they have, which is very valuable when you are displacing such a high density of volume when using dialysis. We can also see a patient's heart status, which is a very beneficial as well, maybe not specifically for patients with chronic kidney disease, even though it's obviously also very relevant, but a lot of patients that are suffering from chronic kidney disease may have concomitant heart failure because of diabetes, for example, or associated conditions. Usually patients are not going to be suffering only from one pathology, and having this very broad perspective into their whole hemodynamic profile is extremely valuable. We can also gain insight into afterload and see exactly what part is affecting cardiac output and stroke volume. In terms of patient transport, there are a few statistics that determine that around 26% of intra-hospital transport of clinically ill patients lead to either life-threatening events such as arrhythmia, hypotension, and also in some cases even death. And the American Heart Association emphasizes that after a patient has arrested, they should be monitored very closely, as they can also suffer from hypotension, hypoxia in around 28% of cases. In a patient undergoing transport, the risk is usually associated with a decline in the patient's status or accidentally related to a patient monitoring, and therefore it's important to have a patient adequately monitored to the best of our ability. And this is why electrical cardiometry is a very good option, because it can allow us to gain insight into a patient's hemodynamic profile without needing all of the usual logistics and invasive measures that would not be feasible within the context of transport. So some guidelines that have been described is that usually, especially with severely ill patients, you're going to want a minimum of 2 professionals. You're going to need basic monitoring, which includes BP, ECG, pulse oximeter, as well as a cardiac monitor and potentially a defibrillator in the case of the patient arrests. And usually you're going to want to fully avoid transporting patients who are hemodynamically unstable. Over here we can see a little bit of an image that determines how the icon is seen in the context of transport. As you can see, it is completely feasible. It's, apart from the fact that the icon itself is a small machine, you can also plug it into a bigger screen. and it's very easy to transport and interpret a patient's hemodynamic status. Some studies have determined that electrocardiometry is reliable as a continuous technique, and not only for adults, which is one of the key factors that differentiate this sort of electrocardiometry from other available options, which is the fact that it can be used in neonatal transport. This is the study in which this was, the poster in which this was determined from a hospital in Paris. And over here we can see the hemodynamic status reports that we can gauge. We can put different stages in a patient's treatment line. We can see the impact that treatment has had on a patient's status report. We can have before and afters. It genuinely is a very comprehensive way of gaining insight into a patient's status. This is how it's seen in the small screen without the bigger add-ons. And now we're going to go through a little bit of a case, and essentially we're going to go through a case of hyperfiltration in which there is a loss of volume due to the speed of plasma filtration. This is going to be the case of a 68-year-old patient with a history of end-stage renal disease and also hypertensive nephrosclerosis, type 2 diabetes, and ischemic cardiopathy. Like I was mentioning before, it's very common for patients to have all of these comorbidities and therefore also be having several treatments, such as this patient does, such as carvedilol, losartan, atorvastatin, insulin. As you can see, he is receiving a lot of different treatments, and we have to know the impact that they have not only on contractility, but for example, on volume status. We can see over here that his interdialytic weight was around 3.2 kilos. And his blood pressure seems normal, heart rate seems normal, he's saturating well, his temperature is good, and his capillary refill at that point is also good. However, upon beginning hemodialysis with a standard rate of 3 liters and a temperature of 36.5, which is the recommended temperature for dialysis, he remains asymptomatic. However, around the second hour of dialysis, the patient starts reporting mild nausea, which is one of the signs that a patient is suffering from intradialytic hypotension. We can see the BP falls. It doesn't necessarily look severely hypotensive, but if we compare it to the patient's baseline, it has significantly dropped and his heart rate has increased, which is showing a need for compensation. We're going to think of 3 main differentials for this patient, such as hypovolemia, secondary to ultrafiltration exceeding the plasma refill capacity, which is the most likely given this context. We could also be suspicious of cardiac dysfunction, such as myocardial stunning, given that the patient does have underlying ischemic cardiopathy, and we are not sure if it may have worsened because of this sudden change in volume that occurs in dialysis, and it needs to be adequately discarded. As well as finally altered vascular tone, which could be related to the dialysate temperature or autonomic dysregulation. We're going to probably go in the specific case with the first option because, as we can see, the cardiac output decreased from 5.2 to 3.8, so we know that the patient is not having enough volume, and we can see that this is likely not due to the contractility because the icon index is preserved. It's within the baseline range as determined through electrocardiometry. We can also see that, of course, the TFC has decreased, which is also going to be more suggestive of hypovolemia because it's, as we've previously discussed, it's a parameter that measures a patient's volume status, and as well as the stroke volume has also decreased, with the rest of the parameters being relatively normal. This is essentially why it's important to have access to non-invasive techniques, and electrocardiometry is a very strong option for this, and it can be used within patients that are receiving dialysis and can't necessarily receive invasive monitoring. It's not worth the risk, but it can allow us to gain very quick insight into specifically what is going on with a patient. And in the transport phase of patient transport, of course, within neonates, but also adults, it can be a very strong option to consider. Over here, these are some of the sources that have been used in the transcourse of this presentation. And if you have any questions at all, don't hesitate to reach out. All the images were sourced from Google Images, and thank you so much for your time. I hope you have a great day.